Hello, I'm murtuza ghiya, and in the previous segments I've discussed some aspects of burnout. I'm trying to create awareness. I've given an introduction to burnout in the previous segment, and through my story, through some brutal honesty in that story, I'm trying to tell you that burnout is real. It can happen to anyone. In this segment, we're going to discuss some factors that lead to burnout and discuss some practical tips which I have practiced and I feel have benefited me greatly in trying to recover from my burnout. In my burnout phase, I had researched and I found multiple scientific articles, 20 odd scientific articles, of which I've taken two and used them as my basis for this discussion. One is the Maintaining Well-Being in Emergency Medicine from the Royal College of Emergency Medicine, and the other one is Strategies for Coping with Stress in Emergency Medicine, and this is from Journal of Emergency Medicine, Trauma and Shock. It's an Indo-American journal. Now these 7 factors, as per the JETS article, lead to burnout, may be more specific towards emergency medicine, but can be used for other specialties also. In this segment, I'll be talking about the first 6 factors. The 7th factor will be discussed in another segment in good detail. First thing, of course, is simply the lack of awareness. If there is no awareness, then you're more likely to undergo burnout because you don't even know you're going through it. And how can you possibly find methods to fight it? There is great hope in my heart that this discussion here will create some amount of additional awareness. There's also hope that you will discuss this and talk about this with your friends and colleagues, which will then further awareness. Through the awareness, I hope that someday there will be a well-being committee, a formal well-being committee in every hospital. And yes, I hope that at the level of strategy making from the government, we'll have preventive strategies for all healthcare professionals. Mortality is a significant problem, more so in emergency medicine and critical care. But again, in emergency medicine specifically, the uncertainty of the mortality can create a lot of pressure on the emergency healthcare providers. It can leave you with a feeling of depression and guilt. It's because if the patient expires in your care, you're constantly second guessing. Did I do everything right? Did I miss something out on the algorithm? Could I have done something more? And then you end up with a feeling of failure. And you go back home with this feeling almost every other day. Sometimes there are some patients that have been coming to the emergency regularly and you have a rapport with them. Also, sometimes there are patients whom you just feel you connected with and you have a bond. And when they expire in your care or the family members are there with you and you feel the connection with them, you start feeling that you are also grieving like a family member. The ways to mitigate this is just a simple post-death debriefing. The ideal guideline is if you spend 10 minutes on the scenario, you spend double the time debriefing. But in this case, in busy departments, I understand it may be almost impossible. But I urge you, spend even 2 minutes, 3 minutes at the end of a mortality discussing feelings, not scientific facts that can be done on another day, but just feelings. What did the senior doctors, junior doctors, nurses feel at the end of that mortality? Once you've had a mortality that's significantly affecting you, seek comfort in your family and friends. Talk to them about it. The next day after a mortality, you should be looking to find more rest than usual. Find a different method of relaxation and some diversion. Don't treat it as just another day at work. It's not just another day at work. We all are guilty of not putting any effort in nutrition and hydration on busy emergency medicine shifts. Because we just think that no, after the patient clears out, then I will have my meal. But the emergency patients never clear out. There's always a constant flow of emergency patients. At that point, remember that you can take small breaks. This is what I started doing eventually. I started keeping small snacks, healthy snacks in my pocket, and I would just take 2 or 3 minute breaks and keep munching on these snacks. It's important to do this regularly at every hour or every couple of hours, because then at the end of your shift, you're not exceptionally hungry and you avoid overeating. Similarly, water is absolutely essential. You have to have a fixed source of water there I tend to measure water. I tend to have 2 liters of water on every shift. Well, in my phase when I was burnt out, I was just simply exhausted, too exhausted to not even exercise, to even think about exercise for that matter. And then when I was starting to recover, I did a course on Coursera. And this course was run by Professor Chris Oliver, who is a trauma surgeon who had a severe degree of burnout, and one of his trigger factors for the burnout was simply a poor lifestyle which led to morbid obesity and complete lack of exercise. This course then, through this course and through this campaign, which is sit less and get active, you will see it online. This surgeon managed to inspire many people from there to there. That's his journey. I've soon now started cycling to work. I've also started running at least 4 days a week, and I do some amount of muscle strength exercises at least 3 days a week. I've done a full 10-day course in meditation in the Vipassana Center. I've also done a 3-month yoga course and learned to imbibe some of that in my practice. Now, exposure to infectious disease is particular, not just in particular to emergency, in relation to emergency medicine. This is there throughout the hospital. Almost 50% of all residents said that they had at least one exposure to an infectious disease. This can be mitigated by simply having adequate space and well-designed and well-separated equipment. I understand in busy, crowded emergency departments, this may not be possible. But then, at least in your resus bays, where maximum number of invasive and active participation of care is being taking place, is because of high adrenaline rush, more chances of errors. Sorry, I just want to redo this slide. Yeah. Exposure to infectious disease. It's shocking that almost 50% of residents have had at least one exposure to an infectious disease in training. To mitigate this, it's important to ensure adequate space and well-designed or at least well-separated equipment in your department. It may be difficult in many Asian hospitals where it's so much overcrowding. But then remember, in that case, at least in the resus bays where there's high risk of needle stick injury, at least there to keep some amount of space. Careful disposition of all sharps, not just for yourself, but also for the benefit of your colleagues. It's important to prepare for a procedure. You have a big procedure lined up and you can't just jump into it. Keep your trolley well prepared so that you know what is kept where, and when you're not looking, it's less likely that you'll put your hand onto a sharp object. Emergency medicine has 3 times higher rate of substance abuse. We have to promote confidential self-reporting. This can generally be done if your emergency department is like a family and there's so much camaraderie that there is confidential self-reporting and there's a feeling that you will not be judged. A feedback needs to be done regularly from co-workers about each other as to if anybody is developing any substance abuse behavior. And yes, once some problem is picked up, you have to have a formal pathway for its treatment. You cannot expect someone who is burnt out and abusing substance to find his own way into treatment. This is one of the biggest sources of worry, lawsuits, and this happens predominantly in the West. In Asian populations, the angry or disappointed family members or patients find other methods to express their anger. They may use sticks, punches, they may use stones, as you can see here. And it's unfair for any healthcare professional to work under the pressure of this happening to them. And if this constantly is running at the back of your mind, you cannot do justice to your patients. In fact, then you start changing the tests ordered because you want to practice defensive medicine. You start documenting differently and your treatments change. How to mitigate this? Simple education. The first thing is academic education. So if you know your textbook really well, you know the guidelines really well, whatever treatment you're administering, you can confidently go about doing it, because then even if the patient does not do very well, you always can say that is because of unidentifiable factors, because the treatment was done perfectly as per guideline. Additionally, you have to look outside of our textbooks also. I know we are not formally trained to do this. We are only trained to look at hard medical facts, but sometimes we have to look beyond that. I went for a 1-day course in current legal updates in the law of land for my country, and that's helped me understand and feel less fearful about what can go wrong with respect to legal aspects. Once something does go wrong at work, it's important to be able to discuss these lawsuits with your family and friends and not to hide the fact that something did go wrong at work. It's largely because you have to understand that the burnout and the stress that you are going through is not purely yours. It also belongs to your family and friends. Please be open and share it with them. With that, I'd like to conclude this segment. I hope you'll join me for the next segment where I discuss sleep-wake cycle in great detail. Thank you for your patient listening.